Dr. Demetrio J, Aguila III, and I am the host of the Direct Care Movement podcast, where we're going to dive into questions about medicine and money and where those two intersect. I know that for a lot of you, you may be thinking, that is a topic that we really aren't supposed to talk about in medicine. We're not supposed to talk about money. Well, we're going to dig into those questions. We're going to ask the questions that maybe you've been afraid to ask or didn't know how to ask or didn't know you were allowed to ask. And we're going to dive into that. We're also going to probably dive into some questions that you didn't know you had until you hear them today on this show, and then probably a bunch more. And so hang on, grab on, hold on till your knuckles turn white. This is going to be a great conversation. I'm excited to welcome onto our show today, Dr. Steve Borene. How are you, Steve?
I'm doing great, Demetrio. Thanks for having me.
Awesome. Can you tell our audience a little bit about yourself?
Oh, sure. Like I said, I really appreciate what you're doing here to get the word out. This is really a ripe time in the environment to go ahead and reach out to people, both people entering practice as well as people who are more seasoned like you and I. To begin with, I'm an anesthesiologist. I came to medicine a little bit later in my career. I didn't grow up with an interest in going into medicine. In fact, I didn't really know doctors or doctors' kids when I was growing up. It was never anything that was a drive for me until I had spent some time in the Marine Corps after high school and found my way to college a little bit older than some. I look back, I was still quite young. But when I finished college, as I was wrapping things up, it was a need for something challenging, something interesting, something that I'd always be able to grow on, and also hope to make a living doing it. I figured it was a respectable way to go ahead and do that, and so that was my drive to it. It wasn't very idealistic. It wasn't necessarily to help people. I wanted to be helpful. But it wasn't something that really had moved me in my heart. It was kind of a calculated decision. Continue to move on and gain more education. I enjoyed education throughout, and so I moved into practice there. I did medical school at the University of Minnesota. I grew up in Minnesota. Then did residency in anesthesiology at the University of Iowa. Great experiences all around, made lots of friends. Found a good practice in northeast Iowa, which was about an hour and a half from where I had grown up and where my wife grew up, and found a great group of people in private practice. And I had a lot of autonomy, but kind of felt like I had limited opportunity there. We had the exclusive contract with a hospital. It was like I said, great partners, really got to cut my teeth on how to take care of patients. But we became more and more dependent on CMS payments, more and more dependent on the hospital. They wanted so many rooms and so many people available. And it felt like we weren't moving forward. I had older partners there that knew that things were fine. They weren't as good as they used to be, but they were still fine. And I felt like maybe this was a time for me to make a change. I spent a few years there, and we had a young family, and thought, let's find a bigger town. Let's see what else we can do. And so I took a job as an employed physician in Southwest Wisconsin. And I didn't fully appreciate how much autonomy I had in private practice until I no longer had that. I could no longer waive somebody's fee. I had patients that came in to me in private practice that they couldn't pay, and we'd work something out. I could either give them a discount, or if I knew they were really in dire straits, we like one patient, for example, and I think I've maybe shared this with you before. If he could prove to me that he quit smoking, I'd cancel the rest of his bill. But if he kept smoking, I was going to continue to charge him $25 a month. Until he had squared up his bill with me. And he was able to show to me with a couple of nicotine tests that were negative a week apart that he had given up smoking. And I really felt like I had made a difference with him. And that was a part of medicine that I hadn't ever anticipated being something that made a difference for me, but it started to. And I was just getting a handle on that when I took this employed position. Now I could no longer do that. I had a similar patient as him. I talked to our administrator, and she said that wasn't my job. They could talk to the patient representative. They could work things out. I went and explained it to the patient. He said, forget it, I'm out of here. I really don't need surgery that bad. And that kind of changed my outlook on where I fit in and how the system was set up. And I found over the next several years while being employed that I craved something different. And like I said, I cut my teeth on the anesthetic practice for a while, another decade and a half, when I finally realized what I needed to do was make a change. And I started a locum tenens agency, started kind of shopping my wares with my name, the more typical hang my own shit out, right? To go ahead and show some, this is me. I'm willing to go ahead and make a living and provide my services based on my reputation. And I had a dozen other anesthesiologists that came with me, some from my practice that I had been in for a number of years and some that I had found along the way. And now that practice is still going. We've got our 20th anesthesiologist will be joining us in our group, work primarily in Wisconsin, near Lake Michigan, up and down the side of the state where most of the patients are. And so we built that up, and I found Autonomy, way I could practice, the practice settings that I wanted to be in. I could deliver a salary that I wanted. I could run my own schedule. So I found a lot of the autonomy that I had been missing. But there was still something, and I know, and I had thought I came up with it myself, but I've also heard you and Dr. Keith Smith talking about the same thing, feeling like you're still an accessory to a crime. I don't want to claim that I ever invented that phrase, but that's how we described it. And one of my traveling anesthesiologist partners, Dr. Josh Johnston, and I, we were both continually frustrated and feeling like that. Great example is I took care of a patient on a Tuesday, and he was 53. He had just run a marathon on Sunday, and he did well. He ran faster than I've ever run a marathon. And he looked great. He was coming in for a hernia, an open hernia, as straightforward as it gets from a surgical standpoint. I didn't need to know any more information about him, except that he had just finished that marathon in good time. And when we weren't in the operating room at 7:15, I asked the circulating nurse, why aren't we here? And she said, well, we don't have the results from the EKG. I said, well, I don't need the EKG. Nobody else, no other physician is going to look at this EKG. Why do we need to have this? And she said, well, it was ordered. And I'm not in the habit of just canceling another physician's order. So I contacted that physician. And amazingly, at 7:15 in the morning, I was able to get a hold of him. And he said, if you do that, I'm gonna take a hit. I need to order that. I know, what was his time? He knew the patient. He knew he ran a marathon. He knew him well. And he said, yeah, I just had to do that because he's 53. I said, that's ridiculous. I'm 53, or I was 53. And he didn't need it. I didn't need it. The patient didn't need it. And so I said, I'm going to cancel. I said, I'd like you to cancel it. He said, well, I'd rather not. They'll come after me. I said, okay, I understand. Do you mind if I cancel it? He said, no. So I did. Between the start of that case and 9 a.m., I had emails from 3 different administrators wondering why I had canceled that test. A perioperative nurse supervisor, some protocol nurse administrator as well as the EKG technician and cardiology representative, explaining to me that the cardiologist needs enough work to go ahead and justify keeping her working at the hospital. And that was really the last straw for me. And I talked with my partner, Josh, and that's where Renovo Health, our current system, was kind of born out of. And that was a couple years ago. We went down, visited Dr. Keith Smith at Surgery Center of Oklahoma. He hosted us for a day. And we looked around and we asked him, and can we copy you? Can we do this again? And he gave us our blessing, gave us a bunch of notes. It was really refreshing to watch him work. We went into the operating room. There wasn't an EMR. There wasn't a Pyxis machine. There wasn't all the tools that we're so used to seeing every day that only exist to go ahead and capture revenue from the system. And it was just good patient care. And we wanted to do that. And that's what we've done. Opened a direct pay surgery, endoscopy, and infusion center up in northeast Wisconsin between Milwaukee and Green Bay. In the last month, we opened our second center, an endoscopy center near La Crosse and close to the Minnesota border. And we found that there's a whole bunch of other people in this space. We had no idea that there were direct pay primary care docs all over. Matt Ort, who you've had on before, last time I talked to him, I think there were 130. There's probably more different practices now. They're doing the same thing, and they're the perfect setup for what we're trying to do. They're trying to be honest and transparent and fair with patients. And when they come to us, we want to be honest and fair and transparent with them. You know, the direct, I've heard people talk about direct pay being, or direct care just being direct pay. Well, it's also, we have a direct relationship with the patient. We have a direct responsibility to the patient and a accountability that nobody else seems to have. And we want to bring all that back to a setting just like any other business would do. And so that's where Renovo Health, and that's how we got connected. We were connected initially through Matt because of those same ideals, those same goals. And for the first time in my career, I actually do have a passion. I am kind of idealistic. I had spent the last 10 years for sure trying to figure out where we were going to retire. We're going to get this retirement home and a second one nearby to rent out and get passive income, all these different approaches that my wife and I had worked on. I have no interest in leaving this. And now this is the most idealistic I've ever been, the most hopeful, and the first time that I actually feel like I'm helping people and meeting them where they're at. So that's my story, how I got into direct care. And as we've learned more and more about that, we find out that how can we help people this way? Right? Bankruptcies. Most bankruptcies, I think it's like 2/3 of them in the US are due to healthcare costs. And most of those people, 80% of those people had health insurance, or what we call health insurance, right? So this is an area where we're missing people, we're missing patients, and we've got physicians that are in this accessory to a crime, kind of Stockholm syndrome, locked into a position that they know they're not happy with, but they don't dare try to leave. We just can't see any other way to get out except through this new system, which it turns out is widespread. Hundreds of practices in our state alone. We're not even the only direct pay specialty center in the state. There's no reason why this can't continue, except for the people that are making, all the middlemen making all the revenue off of everybody else's hard work. We really got disgusted by people, by me assuming the risk, by the patient and me building up a relationship, and then somebody else taking more revenue from that than the patient deserved to have to pay and that I ever received. We built a relationship with that patient in a way that they see value in what they're paying for, but it's not going to the place that they think it's going. It's a $4.5 trillion a year business. Less than $1 trillion of that goes to caregivers. That's 3.5 trillion that doesn't have to be spent anywhere. That's 3.5 trillion that mostly employers are wasting, going to other people who are sitting in their fancy home right on the Jersey Shore, content with their MBA. We've got people adding more technology, which I think is useful, but not necessary. I'm reminded of the Peter Drucker quote, there's nothing so useless as doing efficiently that which should not be done at all, right? You know, we don't need to do all this. We need to go back. We need to go ahead and have what was here 50 years ago. Number of physicians and nurses has doubled in that time. The number of administrators has gone up 3,800% or something like that. Yeah. So that's what drove me in, and now drives the passion for what we're doing at Renovo Health and all the other partners, what we see at Total Pain Solutions as well, all the things that you're doing. There's a lot of people that are doing this, and you can tell who they are because they're the ones that are connecting with patients. They're the ones that are finding a way to go ahead and mutually benefit employers, systems, patients, all of the above. And it's necessary for that to continue.
Absolutely. I'm glad you brought up, something that I really hadn't thought about in that much detail until, I don't know, the last 5-6 years, that this new, what a lot of us are calling a parallel healthcare economy, right? This supposedly new system is actually the old system, right? I mean, with a few enhancements, but I mean, it's basically the way that healthcare was delivered for thousands of years until the advent of health insurance here in the United States.
Exactly. I mean, it's we've got to turn this back 2 generations. It was, and like I said earlier, I didn't have a lot of contact with physicians growing up, but they were respected. They did fine, but people knew they did fine because they worked hard. They were always available, and they were glad to be available, as far as I could tell. The physicians that we came across were personable people whose name was on the outside of the building. If it was a hospital, oftentimes it was owned by multiple physicians, and nobody worried about their ulterior motives because they knew their motives were to take good care of people, and that's how they benefited. They were respected members of society. We don't see that now. We see just the opposite, right? I mean, who are the people that go to the ribbon cuttings? It's not a bunch of physicians. If it is a physician, it's somebody who is no longer part of the brother and sisterhood that we all either were driven to or have found ourselves within, and patients suffer. And all that, the only people that benefit from that are the people who are gleaning off all this capital that need not be shared at all. This should be probably a $2.5 trillion market cap, right? I mean, this doesn't need to be $4.5 trillion every year. It should be 2.5, and maybe a little bit more than $1 trillion of that should be going to the caregivers. And everybody else can coordinate things. There's room for facilitators in there, as long as it's transparent, as long as it's mutually beneficial. But ultimately, we just have buyers and sellers in healthcare, right? I mean, that's the whole idea behind another group that we share in common is the Free Market Medical Association, right? Buyers and sellers. You are one or the other. What are you? And if you can't fit into one of those camps, you better find yourself pretty useful to one of those groups. I don't need a whole bunch of other people to go ahead and connect me with or to do anything in with patients except to connect me with them. If they can facilitate that connection, they're useful. If they can't, make it easy and transparent and visible to all of us and what they're doing, I don't need them here. they're not helping me. They're not helping patients.
Right. So I want to go back to something that you mentioned earlier, which is, one of the things that Dr. Smith loves to talk about. And I, as you know, I agree with him on this, but you mentioned that you felt like you were an accessory to a crime. Let's dig into that a little bit more. What did you mean by that exactly? Again, keeping in mind who our audience is, who may not be familiar with the idea.
Sure. So one of the tenets of what we do in medicine is to explain to patients what they're receiving, what our benefit to them is, right? I mean, and that's really where our value comes. What is my value to a patient? It isn't that I can intubate, or I can provide them with a pain-free surgery, or I can manage their physiology and render them senseless to a procedure. That has a value, but my total value has to do with how I help them understand, put them at ease, do all those technical aspects, but also make sure that it's in their best interest, right? It's a fiduciary relationship. And that's something we talk about in banking. Right? Bankers have a more well-defined fiduciary relationship than people in healthcare, and that's absurd. So we have a fiduciary responsibility to a patient. As part of that, we need to make sure that they trust us, understand, and to truly understand, in order to give informed consent, they need to understand, or at least be aware of, all the aspects of their healthcare. And the part that we overlook all the time is the financial side of it. Great. Medicine never heals. The way our system's set up now is, I guess, babies and cataracts, right? You've got some pretty tremendous success with neurectomies for post-herpetic neuralgias, for example. But we don't really fix that many things in medicine. Most of what we do is we manage it, and that's intentional. Right? We used to fix things. Now we manage things. And as part of that, we move somebody past the acute episode. And for the next year, they're getting new bills. And then 3 years later, they're finally paying things off. In the meantime, they've forgone other healthcare. We get people, our center does a lot of endoscopies. We have people who come in, they were supposed to have their second colonoscopy after they had a polyp found a few years ago, but they put it off for years because they were told it was free. Well, small print says as long as it's just a screening colonoscopy, but they got an $8,000 bill, and wow, lo and behold, that was the size of their medical deductible. So they put off care. How am I doing the patient any favors if I'm setting them up so they won't get care later, so they won't get follow-up? Right? So I'm not giving them, they are not getting full informed consent, or giving full informed consent to me if they don't understand that. And it's my role to make sure they understand that. Now that's difficult for me, especially now, because I've got this avenue, and I still work in the old systems through our locum tenens agency at times. Our business is growing. Until we gain enough market share, I'm going to continue to have to work back and forth. Now, I think that gives me an advantage because I'm continually reminded, and really my heart's been turned against the things that are in that system. But I have patients just last week, maybe it was the week before, early in the week, I had a patient that would have been perfect, would have really benefited from what we're doing at Renovo Health. And where's the ethics, right? Where I'm working with another system. I need to balance, because I'm reminded, who's my master, right? We all know you can only serve one master. And I need that master to be the patient. If the master isn't the patient, then I'm failing in what I'm doing. And so it's a balance when you're in that system. And it's a balance that's set unfairly against the physician because it's set unfairly against the patient. I need to go ahead and keep myself from, it's not just a bad email, it's financial, it's limitations. It is going to remove you from a position of authority. It's going to limit the number of patients you get to see. It's going to do all of that within a system if you don't play the game. And I think it was Dr. Smith is the one on one of your previous episodes. His advice to people is don't go work for a system. Don't, and I couldn't agree more. I think, that's really sound, sage advice, because you cannot serve two masters.
Yeah, exactly. Yeah, I mean, effectively, one of the questions that came up recently, I think you were part of it, part of the discussion regarding physician unionization. I mean, it's a symptom of a bigger problem, right? Physicians in certain parts of the country are unionizing because they're getting beat up by the system. And so the upside is their concerns get heard on a level maybe they hadn't been heard before. But the downside is they're doubling down on a relationship which really doesn't align the priorities correctly. Because what you effectively say when you become part of a union is, okay, I'm an employee of the hospital. I work for the hospital. The fact that I'm taking care of a patient is the mechanism by which I work for the hospital, but I'm still working for the hospital. I'm not really working for the patient.
Right, exactly, and I understand the response, and it's unfortunate that it seems like unionization moves like that are the only way that some people are looking at there being an answer. We have an answer, and here's the thing: we fixed healthcare, right? We're working, you're working, right. Dr. Paul, I mean, you've had other people on as well, who I've interacted with on one stage or another. We're able to go ahead and do this. We aren't restricted. Certificate of need requirements in certain states makes it harder, but you know what? Not everywhere has that, and there are some ways around that. Do we need to spend all our energy on that? I don't think we need to. Do we need to spend all of our energy on finding a way that a group of physicians collectively bargains? I hope not. Maybe that's a step. Maybe that gets people to realize what their value is, and there is a benefit to that. But really, what we need is people to understand their own value. Once I realize that I'm valuable, I mean, if I don't show up to work, it's very easily, and we don't see it. It's not quite as clear cut in a primary care model, but it's so widespread because of how many people are coming in there. So there'll be plenty of people that can go ahead and show where that fits in on that model, because it's exactly the same thing. Just scale per episode of care, and just how they blend things in together. It doesn't match perfectly, but I'll use episodes of care as an example, which is most of the time when somebody comes to see me or come to see you, they have a problem. They're not coming in for everything. They have a problem. And we do life in an episode of care, right? I mean, you need to fix something in your bathroom. You go off to the store to purchase something. If you didn't remember to get something and you have to make a second trip back, that's still part of that whole episode, right? We do life in episodes of care, so people can understand that. Putting prices together for things in an episode of care makes sense, right? Because that's the way we do things. Well, it turns out I can give weight or I guess a number to my value on a number of levels. One, what I'm doing procedurally and physiologically and pharmacologically for a patient. Also, what I'm doing from an education standpoint, what I'm doing to help them set up so they can get the proper follow-up, because I'm making sure that we do this in a cost-effective way. But also, I understand, especially in these other systems, how much revenue is being generated. If I don't go to work, that's very easily $100,000 to $300,000 in an operating room in a day, which makes me valuable to them directly just on that level. But it turns out the circulating nurses also really necessary. And so is the scrub tech, and so is the surgeon, and every member, the pre-op, post-op nurses, right? So all these people together have a tremendous value. And so we need to find a way to connect with those other groups. I agree with that. So if that's what collective bargaining or unionization, or at least that mentality does, I would suggest that it needs to be more widespread. It wouldn't just quite fit with just physicians or nurses. To look at it from that standpoint, I think those conversations are important. Yet I don't, I wouldn't expect to be part of a union myself, because I'm happy to put my name next to the work that I'm doing. I want to show up and negotiate my own prices. I want to be able to defend what my price is. Every dime that we spend or that we charge to a patient at Renovo Health can be attributed to a benefit to the patient. Something that allows us, it might be electricity that keeps the lights on or keeps the defibrillator charged, or allows us to move a bed up and down. It might be an insurance policy or an accountant that's helping me keep things in line. But all those prices together can be amortized and built into the cost of the goods that we sell. And ultimately, that's what I do. I sell a safe opportunity to go ahead and receive a surgical procedure or an endoscopy procedure or a medical infusion. Ultimately, that's what I do. And I'm happy to think of a patient as a consumer, as a patient, as a person. And the only way that I can do that is if it's me personally doing that, not through a collective group. And that goes back to serving the two masters again. If I'm part of a union, now do I serve the union? Well, undoubtedly I will, because I'm human. And that's how we do it. And that's how we're made.
Sure. So let's talk a little bit about Renovo Health. How is Renovo Health different than your typical insurance-based ambulatory surgery center?
Great. Yeah. We couldn't be more different on every level, except for the quality of care, right? We've got the same doctors and nurses that have worked in all the other systems. People generally agree that we get good care from individuals. I mean, there's you're at risk of medical errors when you're in the hospital. There's sources of infection. All of that, there are dangers associated, but the people who are giving the care are good folks who are doing their best. They might be burned out. They might be overstretched. They might be exhausted, but they're really doing their best. And I believe that is almost without exception the case wherever you go. We've got the same doctors and nurses that have worked within every other system. In fact, we've had people come in for endoscopies who recognized our endoscopist on the day of the procedure and said, I thought that was you. And it was the same person that they had 3 years earlier. Well, the only difference was both the initial and the follow-up with us produced 3 polyps. The only difference between the two was an $8,000 charge, right? That was the only difference. The person had the same endoscopist, same anesthetic. Different people provided that, but the same anesthetic, propofol sedation. Left the building within a short period of time, I think out of the building within an hour of the end of the procedure. Everything was the same as far as the medical care. Patient had a shorter prep time. It doesn't take us an hour to get a patient ready for a procedure. It takes 20 minutes because we no longer ask them all the questions that were put on them so that a health system can gain that data, so they can sell that data, so they can go ahead and make more money, so they can get more of the private details of the patient. It takes us 20 minutes. Our nurses were shocked. We had people coming in an hour ahead of procedure and they're like, we got 40 minutes to go. What do we do? Well, in the legacy health systems, they would ask them about weapons in their home and their relationships, and and their support networks and all things that, sure, they play a role, but they don't play a role in what I'm doing. They are important in connecting with the patient. If they're in a setting that they feel comfortable sharing something that they're not feeling comfortable with outside of where we are, we're open to that and we want to address that. But that's not what they come to us for. We don't share that information when we go get our tires changed. We don't do that anywhere else. So why should that be an additional part of a health system? Well, it isn't, because they really are interested in what's happening at your home. It's because they can take that data, they put it into surveys, they sell that data to big tech and big pharma and everyone else that's out there. It's another revenue generator. So we don't do that. And now we've got a shorter patient experience. People don't want to hang out when they're having a colonoscopy any more than they have to. They just want to get there and get it done. So we can improve the patient experience. So we've already got the same quality or better quality because we're not rushed. We can take more time. We can make sure that if there is a polyp there, we're going to find it. If there's a need for somebody to stay longer at the end of the case, maybe they aren't fully awake afterwards, that's fine. We'll take a little more time. We aren't under pressures to try to get the next person in the door to get them pushed out. So you've got the same or higher quality, you got an improved patient experience, and we're doing all of it for about 40% of the cost.
Awesome.
Yeah.
So as we finish up here, Steve, this has been a great conversation. I have two questions for you. The same two questions I ask just about every guest on the show. You could probably anticipate what they are.
Mm-hmm.
Okay. So number one, keeping in mind that our target audience here is primarily medical students, residents, fellows, people who are fresh out of training. What is, if there was one thing that you wish you had known about direct care when you were in their shoes, what would that thing be that you would want to pass on to them?
Well, I think, and I mentioned some of that. I just didn't know it existed. I thought the system that I was kind of laid out, it was laid out in front of me, and like it's laid out for all of us. You do this, then you do this. This is the next step somewhere with a year and a half left in residency. You go out there and you find a job and you get wined and dined a little bit and you're really important. And then you show up at work and now you're a cog. And we all kind of knew that. We used to talk about having the clutch. Maybe people don't know about manual transmissions, but we were being driven, right? You're in first gear and you're just, having to give it all through all your training, just trying to get something launched. And when you got into your private practice, you were going to have kind of clutch control. You could move around and build things like you wanted. And so I assumed, and we all, for the most part, or most of us assumed that was the route. To know that I had options, more options now than ever, is something that would have been really useful for me. Now, I think there is some value in being kind of an old, grizzled guy doing this now. I can see the difference. I'm willing to put up with a little bit more difficulty. I have more patience in trying to achieve what it is that we're all trying to do. And that, I think, has come out of, kind of suffering a little bit along the way. So that's one thing I think would have been really useful for me, to understand the importance or the ability to do things my own way. Sure. Some of the best time we had, I think back to having a young family. I wasn't making any money. I didn't have any time off, and we did ridiculous things to entertain ourselves. And we look back at the, decades later and really find joy in that. And that'd be my recommendation for somebody who's just finishing their training or still has some of that going on. Find a way that's going to work for you. You're going to make a decent living. You don't need a lot. Live smartly. Do what you enjoy. It's all the silly things that you tell your kids when they're in middle school and high school. You know what? We forget that. And I had forgotten it, and I got into the grind, And it took me years to get out of the grind.
Yeah. Last question. How do people find you?
Good way to find us is to go to our website, www.renovohealth.care. More and more of the medical sites are finishing with .care instead of .com now, so that's important. And you can see our story. You can see our mission, our values, our goals. You can also see all the offerings that we currently have. All the physicians are listed. All our offerings are listed, and the full bundled prices are listed. So that's the easiest way. Go right there and check us out on renovohealth.care. And we've got phone numbers. We've even got a fax number. We've got to have a little bit of throwback right there. Email. We're happy to answer questions. I'm happy to talk to anyone. I drive. I live a few hours away from our site, and so I split time with Dr. Johnston, who's there today. And I don't mind having a phone call while I'm driving. So that's always worthwhile. And as just one extra little thought, I'd say I think it's critical for people to know their value and the price patients pay in order to receive our services. And without that information, we're not a fiduciary and we're not truly getting informed consent. So I would say that it's not just a goal. I think that's a requirement. I think patients deserve to get that from us, and I think we're letting them down if we don't. So I would encourage everyone to know their value and realize that this is a really privileged position to be in, and they should never overlook that. And I didn't fully appreciate that until I had been well into it. And the earlier people can realize that and let that be what drives them, I think they're going to find that they get tremendous rewards professionally. But also that's where you'll get your financial freedom. You'll get control of schedules. You'll get control of all the things that we feel like are important on earth by following that route. Awesome.
Well, thank you, Steve, for being on our show today. This has been Dr. Steve Borene from Renovo Health in Wisconsin. It's been a guest here on our show, the Direct Care Movement podcast. If you found this information interesting and you want to hear more, please like and subscribe on whatever platform you're using, and then share this with a friend. Okay, this is what we're witnessing here is a revolution in healthcare, and you can be that revolution. But don't keep it a secret. Spread the word. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.